Hello and welcome to myRNpodcast, the podcast dedicated to providing insight and encouragement to the nursing community. I'm your host, Devin DeBoer. In this episode, I had the opportunity of speaking with Erin Hurd, who is a nurse practitioner and RN. She worked at the Detroit facility, working with the COVID patients there. We discuss what went right, what went wrong at the facility, and how things could be improved if there is another surge that requires government intervention to assist local hospitals with the care of COVID patients. And we also talked about how it was very unique in the fact that the first time that patients did not have family members able to assist with care, but also support for the patients, and how nursing and all the staff were so creative in trying to make it more of a home environment and get access to patients' families as best they could. So I hope you enjoy it, and thanks for joining in. Why don't you start out with, how did you get into nursing in the first part anyways?
I've always wanted to be in the medical field since I was younger, and I just kind of knew that I didn't want to be in school for the next 20 years all straight. So I went into nursing instead. I have my master's in nursing, and I also have my family nurse practitioner's degree. I'm also a RN first assist, so I assist in surgery also. I started out my career 20 years ago in cardiac recovery units, the CVIC. Okay. Did that for 3 years, and then spent the next 16 years in surgery, moving up from there. And then I thought that I could do a little bit more. Instead of going the doctor route, I went the FNP route, which is the same thing. I just don't get called a doctor.
Right.
I'm okay with.
Yeah.
Rather be a nurse. So I love my profession. So that's about how I got into it. And then from then on, I just kind of moved up in my career. And then my career kind of halted a little bit with the COVID and everybody being furloughed and all that stuff. So I kind of went back. I went to travel nursing, not knowing that I'd be able to get in or not. So your company was actually the first company that I had worked with, and I really enjoyed working with John.
Oh, good.
So you guys seem really like, at least honest, and not trying to jerk me back and forth with rates and
yeah.
And you guys answer my questions honestly. But that's about how I kind of got into the traveling.
So can I back up just a second? So you're a nurse practitioner.
Yes.
How does that work? Which license are you working under? Can you work under either or then in a hospital setting?
No, I work depending on what they hire me for.
Okay.
Just be working as a nurse. I can be working as an FA, or I can be working as an NP traveling. Right now, my job with you guys is basically just as an RN, but I have background, so I can take more positions than most people. So that's a little bit to my advantage, because I do have an OR background, I have an ER background, I have a critical care background. So that makes me a little more friendly in the nurse realm.
Wow.
Yeah.
Huh.
And that's how I got into the COVID. The Detroit thing came, and I'm like, well, not sitting. I can't help anybody sitting there. And I've done Haiti trips, mission trips to Haiti for
okay.
I was like, well, this would be looked at as my, I guess, mission trip, except for the fact that I'm getting paid for it. How I took the COVID thing. And that's how I got started with the COVID. But otherwise, I was an RN and an NP.
And before we jump into the COVID experience specifically, how long were you a nurse before you became a nurse practitioner?
I was a nurse for, basically 16 years before I took the 3 years out to do my nurse practitioner. So basically 19 years as a nurse. And then I went to school for 3 years for my FNP. So I've been an FNP for a year. And then I've a nurse for the rest of.
Wow. Okay. That was a brave move to switch from nursing to quit And you had to go, did you take weekend courses? Did you go full time or do both?
I went full time for 3 years, and yep, it took a toll. And then now I have to kind of, if I want to get back into the critical care realm of being an NP, I have to actually prove that I can still do the critical parts because I did family practice for 3 years. So it's almost like reproving yourself all over again. But that's okay. That's life.
Take that in stride.
We always start from the bottom up, right? Nobody ever starts at the top.
Yeah, you want it to be easy, but it's
Sure.
All things that are good, I've learned in my 52 years, are not easy.
Not at all.
Yeah. So walk me through, it's early March and COVID is exploding on the scene. What were you thinking?
Well, I was thinking actually when it was exploding and how I was worried. But I also felt like as a practitioner and as a nurse that I felt like it was almost the second round already, that we had our first round back in early November, December, around there. That
Really?
we had
How so?
And nobody really knew about it. Well, around Michigan, a lot of schools, everywhere, a lot of schools were just closing down because there was just so many flus going around and we weren't able to get it controlled. And everybody was sick and there was all those issues. They couldn't, teachers were calling in. So, I mean, my kids' school were closed down. They literally, like I think a weekend or 4 days. And my daughter at that point, over Christmas break, got really, really sick. And it was a fever that I could not break. And she was sick, like with the congestion, just tired, did not want to wake up, did not want to. So I had Tylenol her and ibuprofen her. And I had thought that it was just the flu at that point, which it was. So I also gave her some Tamiflu. And then I Tamiflu'd everybody in the family just in case. Well, it actually worked, the cocktail that I gave her. So I don't know if it was just the beginning and I caught it, but I really feel like that at some point, everybody's going to get it. I mean, as a medical person, you can't sit there and say, well, we've got this figured out and we've got that figured out in 6 months period of time. No, you don't. Research, you cannot possibly research adequately and have the right trials and have the right information gathered in this many places to make what is actually a correct thing to do and not. So I think we should just admit as a medical community that we don't know. We don't know how this is, because from seeing it, you can be really, really sick, or you can just have a few of the symptoms, or you could have the symptoms really bad and get over it. But I've had personal experience. My friend right now, her father is in the hospital with COVID. And with what I see is, I really do see that if you are truly immunocompromised, and I don't care if you're young, old, middle-aged, you should be careful. Because when you do get it, it is bad. It's not just the top of your lungs or the bottom of your lungs. It's your whole lung fields, and you're basically drowning. And so is there a good way to prevent COVID, I think, from now on? No, I think our world is pretty much changed. And to say that people can give it asymptomatically, or you can't give it unless you're symptomatic, well, that's pretty much with any flu, right? You can't really pass it unless you're sneezing or doing some. But the bad thing about this one is you can be asymptomatic and pass it and not know it. So,
do you think you had it back in the fall when your daughter had it?
I think us as medical professionals, I think a lot of us will not get it. And the ones that do get it are probably compromised. And that's just my opinion. It's not anybody else. It's my opinion. And just for the fact that from my colleagues and I talking, we have been through so much between seeing Ebola and AIDS and I mean, we see all kinds of people. So to say that all of a sudden we're heroes because of COVID. Well, we were heroes before, so that doesn't really, thank you, but it doesn't really say it much because we've been here as heroes all this time treating you. It's just a matter of now it's a disease that affects everyone regardless.
Sure. Yeah.
Care of you, right? And people are like, are you scared? I'm like, well, I'm scared every day when I go to work. I could be stuck by a needle. I mean, that's my job. So am I scared? Sure. And if I wasn't, I wouldn't be good at what I was doing. So I guess my advice to everyone is wash your hands, stay 6 feet away from people if you can. I don't know that wearing a mask is really going to prevent anything if you don't know how to mask. Wear it correctly. You know
it's the right mask.
Or if you're touching your face constantly and then you're pulling it down here, you're not doing yourselves any good. It's almost better, I think, that if you just left it alone as to just social distance. Maybe if you're inside a building in a contained area, maybe you want to wear a mask. But for generally being outside, walking around, I don't think you're going to prevent anything. But again, that's just my opinion and my opinion only. And I want to clarify that.
You don't represent any particular company or anything?
Hospital, any company, just myself.
So what was, so you were in Detroit, and what, you were there like mid-March, or when was that you were there again?
Mid-April to mid-May.
Okay.
That was about the extent of the assignment. So at first, sure, I was pretty scared, not knowing really what was going on. But the further I saw into it, it's like, okay, maybe it's not as horrible as it seems to be. You know what I mean? And I'm not saying that it didn't happen, but I personally, when I was in Detroit, didn't see any of the things that other people were saying that they were seeing, you know? And I don't know if that, and that is definitely a good thing. So I'm kind of conflicted into whether we're scared, you know, like being scared into a disease, then that we have to really be careful, or exactly what is going on, because we just didn't see the numbers. We didn't see the numbers in the COVID. And I don't know. I worked at the I didn't get to actually work at the TCF Center. I was supposed to be at the TCF Center. But they ended up having too many people. So then they cut down this, and then I got sent over to the SCS Center, which is in Novi. And that was the 250 bed one. And honestly, I guess my point is those field hospitals, as you know, from TV, and they were pretty much all empty. I've talked to colleagues from Chicago where they got paid a lot of money to sit there with 3 patients. Okay? So I don't know if I'm supposed to even be talking about any of this because of confidentiality.
Oh, gotcha.
So I can, because they made us sign confidentiality statements as to what we can and cannot say. Or take pictures and things like that. But I'm left to say that I was flabbergasted by some of the things that were, I guess, said by the state of Michigan in regards to PPE, in regards to how things were handled between hot zones, cold zones, or warm zones, and what they called hot zones, which I'm like,
what are those? Define those. Cold, hot, warm?
Well, when you're in a cold zone, that's where you're basically okay and you're free to move about. And warm is like, okay, you're half contaminated, you're half not. So you're kind of be careful there. Your hot zone is like you are contaminated, okay? So there should always be airlocks when you go through. Well, they were talking to the wrong girl when it came to that. I'm like, there's no such thing as sterility in here. They're like, what? I said, you're having us take our PPEs off in the hot zone to go into the cold zone. So we're basically contaminated when we go into the hot cold zone. And they didn't understand that.
Oh, from your surgical background?
Yes.
Ah.
So showing people how to gown, and they were like, well, why are you wearing your gown like that? Why are you doing that? I'm like, well, because this is double protection. I said, if you're not going to give me what I'm like, that one mask you're going to give me, I'm always going to wear that over my N95 because I have to wear that 5 days. This paper mask you're giving me, it's every day. I get to change them. So I always keep that underneath my N95. And they were like, well, you're wearing it backwards. I'm like, no, I'm not. You're wearing it backwards.
Oh.
Outside, the clean one stays on you from the inside that you change every day. You've worn that N95 for 5 days. Now, you can't tell me 5 days of breathing into that isn't going to have a little bit of issue. They were like, well, it's hot. I'm like, well, I'm surgical. I'm used to it. I mean, and they just didn't understand. I'm like, you guys, that's why I'm just going to do my own thing because I'm not going to get you to understand what a real cold zone and a real hot zone.
Okay.
I mean, if you really watch, even TV did it better with the cold zone, hot zone situation. I mean, if you watch some of the movies, including those Ebola movies that used to go out, there is a clear decontam, and you walk in, right? Well, there needed to be a decontam between the
hot and the cold.
I mean, it was just, so what? I walked through 4 empty rooms to get to my lunchroom. So, yeah. And it was just, yep. And there were some people fired because they weren't following the rules. And I'm like, yeah, I'm not having this. I'm like, you can't have all these people in the lunchroom going through every box of food to find what they want to eat. No. I'm like, you just contaminated
everything. Right. Exactly.
I was actually probably more, and I don't know if I should say this, more scared of some of the people, especially like not nursing wise, they knew better, but the environmental people that are there that are cleaning, just like within the hospitals, do they really know what is going on? Prevent the cross-contamination. And at the end of the day, there's not much you can do unless you're in a sterile environment to contain that. It just isn't.
Wow. So what was it? Sorry. What was the typical presentation of somebody that you had in the COVID unit in Detroit?
We had patients that were just fine, that they just tested positive. There was no fevers. No, they came from a nursing home, and we had this one lovely older lady that was there for probably 8 days, and she was like, when can I go home? Because, I mean, she didn't show any other symptoms other than the fact that she tested positive. There was no other symptoms. And she was an older lady from a nursing home. So we just get her back to the nursing home because she kept testing positive. She didn't show any signs. She didn't do any of those, but she tested positive. And, but there's no TVs, there's no phones, there's nothing for these people to watch. So in my world, if you really do have somebody that's older and that's a little bit, already not quite there dementia-wise, they're going to go crazy. They're going to get ICU psychosis from just seeing no sun, no TV, no people other than these 4 curtains. So that's basically one typical lady. And then we had another fella that you could actually hear him, like hear his lungs, like he was like drowning, the gurgling, you could hear him. And, but he had a mask on and he had that, and we had all the precautions, but that was the only thing he had was the chest thing. He was on under 6 liters. He was on 2 liters, I think, when he came. And, but you could tell that, but he was doing fine other than the gurgling and doing all that. And I think as long as you keep those people moving, as long as you can before they get to the point where they need support, if you kind of try to give them the CPT treatments and trying to do the proning if you can, and getting them up, just moving, maybe walking, something to help with those lungs. But it certainly doesn't help when they can't move to, try to clear their lungs. So he was almost on his way out. Because we didn't take anybody that would have to be ventilated. We had very minimal capacity at those. So we had teams that, if they were to crump, there was an EMT and the team there to take them right back out. So we were ready for that. And the other few patients that we had, honestly, they were just tested positive from facilities that they were at, and some facilities, And I think they were expecting a lot of homeless people, and people that there wasn't. Oh, hold on a second.
Yeah, you're okay. No worries.
Really any of those to be. So, I'm sorry, where was I at? My dog just interrupted me.
Symptoms of the COVID. You were walking me through the different patients.
Yeah. Most of the other people that I had, honestly, they were just tested positive. Like there was this younger gentleman, and he had, he was mentally disabled. So there was a hard time keeping him quiet and down, and but there was no other issues with him either. So it was almost like the field hospitals were used as symptom controllers, to see if they were going to turn. And if they do turn, then we ship them out, was more of how that worked. But and from what I saw, the COVID testing centers, all of that, there was no lines. There was no people waiting. I mean, most of them were empty. So from my standpoint of what I saw, I'm conflicted as to what was reported and what I saw. And I'm not saying that other people didn't see things differently, because they were but from what I saw, it really, like I said, if you got it and you are immunocompromised and older, and you just happen to have hit it right at that time, you're going to get it. And it is bad. I mean, and we're looking at people with peak pressures of up in the teens, and you don't see that as, the highest really I've seen in it, maybe 5 of peak. These are people are at like 9, 10, and we're trying to wean them off. I'm like, well, you can wean oxygen all day long, but if you can't wean them off the PEEP, you're not going to get them off. Because if they need that much pressure, you're not going to...
It's not going in.
Yeah. So...
Yeah.
So
how hard was it on the patients, that they couldn't see family, they couldn't do... How hard was that on patients and on you?
It was hard because there was no communication. All we had was basically iPhones. We had hundreds of iPhones ready to go. So the family could call in to the central phone, and then we could patch it up. We would give them the number to the nurse that had the phone, and then the nurse would talk to them. Or if the patient was capable enough or coherent enough, we just let them sign it out a phone for them, like an iPhone. That way they can watch TV. Like one of the older ladies, it was a small screen, but she loved her NCIS. So we put the app on, and we put everybody, between all of us, we had Prime or Hulu or something. Right, yeah. So we did let her watch, her TV. So we did the best we could to try to keep them, comfortable as much as they can be. Some of them had their own, so that was good, the younger ones. But there were showers, there were, we fed them. Not that it was the greatest food in the world, because, but it was decent. And Yeah, they were pretty bored. They miss their family. Nobody can go in. Nobody can go out. They can't. We didn't want them bringing in stuff.
Mm-mm.
That was the issue. That was another hard issue. Is that we don't want you bringing in anything. That's And then, other than that, I think if there were more things to do for them, it would have been probably a little easier stay for them.
Mm-hmm.
I think it was especially harder for the younger ones, not so much the older ones, because there's really nothing to do.
Did you allow them to walk outside of their room, so to speak? Like, was there an area that they could walk?
Well, yes, because the whole facility is open, basically.
Okay. All right.
So there were just shower curtains, kind of, or whatever kind of curtains you want to call it, separating the rooms. I could probably send you a picture of how it was. Rooms were allocated. I did take pictures of that, and there was no patients in there, so you can feel free to probably look at that. But yeah, that's pretty much about it on the family aspects.
Do you think that our response as a state/country, the government involvement, it's so hard to say, you're trying to respond as appropriately as possible. Did they over-respond? Did we over-capacitize the whole thing? Or what? Or was it right on target for what was projected? What do you think?
Well...
Or can't you comment? That's fine, too.
No, I can comment. I just feel like that. Now, this is not a political statement where I'm not for or against Trump, but I think that he made the right decision to not let people into the country. I think that was actually a good decision because we didn't know what was happening. So in that aspect, I don't think we moved too early. When it came to the field hospitals.
Yeah, I'm thinking more along that line, the healthcare response, I guess.
I feel like that if it was as bad as it was, we would have taken more patients in the field hospital. You know what I mean? Make it less. I guess my response would have been, I would have allocated all the critical stuff to the field hospitals and kept the hospitals open for the general public so that we didn't have, but that's my view. Because then you would have had all those people contained in one area, the COVID patients in one area, instead of having them in all different areas in the hospital. You could have had the ER, you could have had an ICU part and a step down in that 1,000-bed facility that you opened up, okay? And where were all these ventilators that people said were coming, or where that was being allocated? So if those are being allocated, I thought I get it, you keep the ones that you need in the hospital, you allocate everything else to the field hospitals. That way you have capacity there, take care of the worst of the worst patients, and then you keep the hospitals safe where people can still do their procedures and still do their stuff so that... So I think our response in that aspect was kind of back-ass, and that you should have taken all the what we call dirty patients, sent them out, and had the people that were, clean and uncontaminated in the smaller hospitals. Because there was that big of a mass of people that that took up every hospital that was around the city. Then the thought would be behind setting up a field hospital for all of that to contain it and keep it out of a certain area. But instead, we saturated all the hospitals around the area so that every major hospital had issues, So in that aspect, I feel like we could have planned a little bit better on that. So maybe if there is a third wave, like they're saying, maybe they'll try to do that instead.
On that note, do you think there should be a kind of a field hospital response in let's say, the fall, or should it just be government steps in and supports whatever's there.
I think they are expecting another third wave. I think that they should set it up. Not so, I don't think you need 1,000. You can always add, you know what I mean?
Sure.
But to all of a sudden say you need 1,000 beds, well, we don't know that. That's a lot of people to allocate and then turn around and say, well, we don't need you after you made plans to be somewhere for months. And they're like, oh, we don't need you now because we were overzealous.
Yeah.
So I would think that they would put little field hospitals around the major cities, put ventilator capacities in those so that if it hits again, those people can go to the field hospital. Our major hospital can stay open and do what we need to do, especially now that if we say that we're prepared and we have the masks and we have all those and it's in preparation, I don't know why we couldn't switch that around and allocate a field hospital for that and keep our system going with regular patients there and surgeries.
Boy, if we could keep the regular hospital system going, that would be huge for the hospitals. I don't know if hospitals can. I mean, they just got through with a huge hit. They're just hurting.
Well, what I'm saying, if they can literally, that's the only way I see our hospitals continuing to work is if this comes around again, is to set up a field hospital where we can take those people, where we can get them out of our hospitals so that we can continue to see regular patients and to see, you know what I mean? You can have a clinic set up that's an outside clinic for COVID clinic. And keep your regular family practice and all those people doing your family practice stuff.
Mm-hmm.
I mean, as much as I love telemed, you can't do a physical exam over a telemed. It's called a physical exam for a reason. I have to physically touch and see.
Yes.
I mean, you can point, this hurts. Well, I can't see that.
I can't feel it. Yeah.
Yeah. I think that a lot of people, I think, are trying to use what has happened to, venture out and kind of, do more telemed medicine. That's great. But still, I don't know. I mean, even for a sinus infection, I can look at you and say, well, you don't look like you have a sinus infection. You know what I mean? I have to be able to tap you and see if you hurt. I mean, when am I going to say, hey, tap yourself and see if it hurts?
Yeah. Define hurts. Is it sore or, it's like...
What are you looking at? I mean...
Yeah.
So, yeah.
For work, I had to have a physical after the COVID, so they called me, and my doctor was like, it was good for some things, but other things, it just doesn't work. She's like, you know how hard it is to figure out a rash when you can't see it? She's like, I can't, and then you got somebody holding the phone at an angle, you're like, back it up, no, bring it closer. It's like, I'm just guessing.
Yeah. Well, then it's like, oh, maybe it's scabies, maybe it's this, maybe it's that.
So you were saying, we were just discussing what works on telemed and what doesn't work.
Yeah, rashes are hard. I'm like, is it a sandpaper rash? Is it in between? Is it a poison ivy? Is it a poison? I don't know. So, yeah, it is difficult. She's definitely correct in that.
Yeah. Would you venture out and if, let's say we do have a third wave and there was an area that got hit hard, would you jump on and do it again?
Absolutely.
Cool. Good.
Yeah, I've always been the type that, what did I go into medicine for if I'm just going to sit back when something happens? So, I mean, I personally feel like that if you went into the medical field, you already knew that you were in for some type of somethings. And people are like, well, if the vaccine comes out, are you going to get it? I'm like, by choice? No. I said, but I guarantee you my work will make me get it. So it doesn't matter. So by choice, no, I won't get it, but I'll end up getting it. And I'm like, and I'm pretty sure that we won't have a vaccine anytime that works.
Really?
I don't think so. I think we're at 2 years out.
Really?
I don't care. Everything is, I feel like that everything is, I mean, unless they've got everybody in the world working on it. But if you look, the trend has been, oh, we tried this, and no, 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 no. Now that doesn't work, and we're going to try this. And no, 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 this doesn't work, and we're going to try this. And I'm like, how about we just admit to the fact that we really don't know at this point, and we're trying to figure it out. I think that's the best answer to give people instead of saying, well, it's this, well, it's that. We don't know that. What's the
normal life cycle to develop a vaccine? Isn't it like a year at least?
At least. Otherwise, we have vaccines for, you know what I mean? To develop the right, and it's ever changing. That's why your flu vaccine doesn't work all the time on certain, because it's ever changing. It only does so many types of flu. It only does so many types of. That's why in the world of medicine, there's like different types of medicine that works on even allergy medicine. You know, one may work for another person, whereas another one doesn't. One takes care of 10 anti-inflammatory response, and the other one takes care of 1 or 2. So it's a matter of choices of medicine, and I think really at the end of the day, what works for one may not work for another. Like any med is how I feel about it. So you can't say, I just don't think that you can firmly say this one cocktail works for this particular thing. I mean, just like the Tamiflu, it lessens your symptoms. It doesn't cure your symptoms. It doesn't do any of that. Mm-hmm. So, and right now, if they are saying that it's viral and it's causing this, what antibiotics is going to work virally? Unless it becomes a bacterial. At the end of the day, is the antibiotic really working? And then are we really creating another antibiotic resistance if not work? I mean, there's a lot of questions that people are probably looking at me like, who are you and why are you asking all these questions? Time, I guess.
Yeah. Well, I've spent 20 years in the nursing field, so I know a thing or two.
Yeah. So I'm like, hey, I'm just going to go with the flow. People are like, aren't you scared? I'm like, well, if we haven't learned anything from this, it's like you can be scared. It's still going to come and get you.
Yep. Yeah.
So you live for today because you don't know what tomorrow may bring.
Yeah.
So, yeah.
So you don't have any other underlying health concerns that would put you at a higher risk then as a health professional. So, yeah. Okay. Yeah.
No.
That's good. Let me go back to your initial training. Where did you get your training for your surgical nursing that you did?
At Memorial. You just transfer into different departments, basically, once you get your RN.
Memorial where? Sorry?
Memorial Hospital of South Bend.
Oh, okay.
It's a trauma center.
Okay.
I basically got in as just a nurse, and then with experience in the year, I applied for a FA position, and then they put me through school for the FA position, which is a certificate. That's how I became a surgical. But I got my nursing degree, my baccalaureate from Bethel College.
Oh, yeah, in Indiana, right? Goshen, right?
Bethel is in Mishawaka.
Mishawaka, okay.
Goshen, I graduated from Goshen with my master's.
Oh, wow.
So, yeah, that's in Goshen College. Okay. I graduated with my master's there. Yeah, and that's how I began doing that.
Wow. And are you a night shift, day shift? Do you flex with either? You have a preference?
I'm a night person. I can do anywhere from, I can do days, I can do evenings. I can do 12 hours, I can do 10 hours. I prefer 12 hours because that gives me 4 days off. But then it depends if there's call or no call. So.
Gotcha.
Yeah.
And I always like to ask people with experience, such as you, if somebody's thinking about going into nursing, what would you tell them?
At this point, I would say unless you really, really love it, don't go into it thinking that it's the money, because it's hard. Um, Honestly, I don't think that nursing programs now teach enough clinical.
Okay.
They teach too much books. I think they emphasize too much on the baccalaureate and master's program, that you have to be a baccalaureate. And, well, that's great that we can write papers and push papers, but you've got to be able to push drugs and know drugs and read the patient also. It's not all about the books, is what people don't understand. It's like, you got to match the number with the patient. You know, if the thing says asystole and he's sitting there talking to you, he's not asystole, right?
Right. You have to use your filter, right?
I'm like, you have to look at the patient. Don't just look at a number, because the number will lie.
It's like the pulse ox saying 82 and the guy's talking to you and he's not pallid, he's not short of breath. And you're like, well, obviously this is wrong, right?
Yeah.
Right.
Exactly. So it's like, and if you're counting on your pulse ox to tell you whether your patient's crumping or not, you're too late. Because that's like the last thing you want. So if you really want to check if somebody's asthmatic or really has a lung problem, try to do a spirometry. It might work better to test it out. But yeah, that's how I feel about that.
And where would you have the new grad nurse start? Would you have them to do the traditional med surge, kind of get a broad view first, or what would you suggest?
Actually, I would really suggest a program where they put them through the paces, like a semester of med surge, a semester of critical care, a semester of labor and delivery, like all the stuff that they would want to,
Do they have those these days?
They no longer have that kind of program. They should definitely have those programs where, you do certain amount of book work, but yeah, you learn to work with you go to the hospital, you work 8-hour shifts. That's your clinical. Clinical these days, unless you want to put effort into it, I don't feel like it's much. You get a day or two in clinicals in a semester of whatever. You don't really learn much from that. And that's how I feel about it.
But is there hospitals that will hire somebody to like rotate through those systems then? Like start out med surge, go to ICU, go to labor and delivery. Do they do that?
They have their own float pool, but you have to be pretty good to be in a float pool.
Oh, okay.
You get ACLS certified. Because if you're floating to every, different types of floors that they need you to as a nurse, you better know your stuff.
Yeah, okay.
Unless it's just, I guess you could have critical care floats and then you can have regular med surge floats. And I guess there's different type for different
sure.
cap.
Mm-hmm.
Oh, yeah.
Anything else you want to comment about the whole COVID experience? Anything, recommendations for us for the fall, for the third wave or whatever they're calling this wave?
Yeah, I honestly think that we are, they think it's the second wave. I think it's the third wave. And I really don't think, I think you're going to see a higher number of positives because I think more tests are readily available now.
Mm-hmm.
And I think there were positive people to begin with. It's just that we didn't have the capacity to test anybody. So I think a lot of people are just, it's going to be like anything else, I think, after a while, and you're going to build up immunity to it. And what the medical community like to call it is the, herd immunity, where everybody gets it. That's what they want, is basically everybody to get it so that we're all immune against it. But I have a feeling, honestly, that is what's happening, that you're going to see people that are positive, but they're not going to show any signs or symptoms. Now, the only question is, can they pass it to you with no signs and symptoms? Because if it is signs and symptoms, if you have the signs and symptoms, and that's the only way you can pass it, they're saying, then I guess you're okay if you have no symptoms.
Yeah.
So I guess it really depends on how you look at it. Right.
Yeah. Switching gears, I hear you have is there a Munson opportunity you're considering?
There is a Munson opportunity.
Oh, cool.
And they just came back and they are not willing to pay for what, I mean, it's a certain amount of money just to live up there.
Oh yeah, I lived in Petoskey, so I know.
Yeah. So I'm like, no, you have to actually make it worth my while to get up there. And John's and I'm like, you know what? I'm confident that they'll either take me or they won't. But I'm not willing to go at that price. They know what I'm worth. I've already spoken with the director. They know my capabilities in the OR, and I can do all the services that they've asked. So I'm like, John, just trust me. They're saying, well, we have tons of other people in line. I'm like, well, then let them get the tons of people in line.
There you go. Mm-hmm.
Because I think they're bluffing you.
There you go.
They're not? Okay, there's other opportunities I'm willing to wait for. So
there you go.
Yeah.
You know, I really like that approach. And yeah, there are certain companies that I really enjoy working for, and others I rather not. But and I always trust that the right opportunity is going to come along. You know, so I trust that, and I honor that. That's true.
I'm like, you know, I know what I'm worth, and I know my capabilities. And from what you're telling me and reading me, you don't have the people. You're just starting it. So if you have people lining up for that price in Petoskey, go ahead, let them take it. I guarantee.
Mm-hmm.
So.
Yeah.
Yeah, but hoping. We'll see.
So
We'll see what they're back at.
Yeah. Have you done anything in between the COVID and this?
I have not actually, just taken a break. My hospital wants me to go back PRN and work there, but I don't know if I can fulfill their PRN if I take a travel position, and I don't know if they're willing to hold that. So I'm just kind of sitting back right now, seeing what's going on and living day. Well,
yeah, every day is a gift, isn't it?
Well, it kind of is, between, you know, the rioting and the COVID and all sorts of stuff going on in the world. I don't even know what's going on.
Mm-hmm.
So it's like, yeah, live one day at a time and just try to be happy.
Mm-hmm. Yes. So you have how many children at home?
I have 2 children, a 13-year-old daughter and a 17-year-old son.
Oh, yeah.
Yeah.
So you have to make it worth your while to go up there, because they're not.
Yeah. So I'm leaving my family behind to do this, and I don't mind doing it, and they don't mind me doing it. It's over the summer, and they can always come see me.
Oh yeah.
But I'm not going to pay $5,000 in rent and have you pay me that. I don't think so.
Right.
So I wouldn't even make it worth my while unless I'm just working to play, and I'm not working to play.
No. You can do that at home.
Exactly.
Oh, well, thanks for your time, Erin. Appreciate it so much. Yeah, this is awesome.
Well, thank you for interviewing me.
Yeah, appreciate it.
For working with you guys.
Yeah. Well, you take care, Erin.
You too.
Bye-bye.